Hello guys, this is our first video from this new series that is pediatrics in 10 hours. So first we'll start with genitourinary system from pediatrics, and so first topic will be on glomerulonephritis. It is one of the important repeatedly asked question from genitourinary system, and we'll see about post-streptococcal glomerulonephritis in this video because it is the most common cause of glomerulonephritis in children. And yeah, let's start the story. And the story of post-streptococcal glomerulonephritis is very simple. And before starting that story, we will see about some characteristic features of glomerulonephritis. So when the glomerulus is affected in a kidney, it will lead to certain manifestations like hematuria, RBC cast and dysmorphic RBCs. So when there is hematuria, the patient will come with the complaint of cola colored urine, and hematuria is the hallmark feature of glomerulonephritis. If you see hematuria in the question, you can think of glomerulonephritis, and there will be also RBC cast and dysmorphic RBCs in the urine. So when you see the urine analysis, there will be RBC cast and dysmorphic RBCs. Why there is dysmorphic RBCs means when the RBCs pass through the damaged glomerular membrane, its RBC membranes will also get affected. So the shape of the RBCs will become distorted and it will appear as dysmorphic RBCs. In this picture, you can see the arrow marks which depicts the dysmorphic RBCs, and there will be mild proteinuria in case of glomerulonephritis, but it is one of the major differentiating point between the nephrotic syndrome and nephritic syndrome. In nephrotic syndrome, you will get massive proteinuria, so we'll refer to it as nephrotic range proteinuria. The nephrotic range proteinuria is more than 3.5 grams per 24 hours or more than 40 milligram per meter square per hour. This is the massive proteinuria which is seen in nephrotic syndrome, and in nephritic syndrome there will be mild proteinuria less than 3.5 gram per 24 hours, and there will be edema, hypertension and azotemia. Azotemia is increased level of ammonia in blood. So these are the important characteristic features of glomerulonephritis. If you see these manifestations in a case scenario, you should write the diagnosis as glomerulonephritis. And coming to the story of post-streptococcal glomerulonephritis, we all know that PSGN is the most common cause of glomerulonephritis in children. So the organism which is responsible for it is group A beta hemolytic streptococcus. First, what happens is the streptococcus bacteria causes infection in the form of pharyngitis or skin infection. It can cause both skin infection and pharyngitis. It can cause pyoderma impetigo like that. And if it causes pharyngitis, the lag period after which the kidney will be affected is 1 to 2 weeks. The lag period here refers to the time period between infection and impairment of renal function, that is nephritis. So that lag period is 1 to 2 weeks in case of pharyngitis, throat infection, and 3 to 6 weeks in case of skin infection. So here's the pathophysiology. What happens is after the infection subsided, that is after the pharyngitis or skin infection subsided, the streptococcal antigen and the antibody which is produced against it will combine and form an immune complex. That immune complex will deposit in the kidney and it will cause kidney renal impairment. That is going to present as glomerulonephritis. And since it is happening after the infection of streptococcus bacteria, it is called as post-streptococcal glomerulonephritis. And the age group affected is generally 5 to 8 years old children. And these are the investigations we should do for diagnosing glomerulonephritis post-PSGN. So the investigations are ASO titer. We should see ASO titer, anti-streptolysine O antibody titer. It will be increased in case of PSGN. If it is normal, we should check for anti-DNase B antibody. And next investigation is serum C3 levels. Serum C3 levels will be reduced because in the process of immune complex formation, these complements will be utilized. So serum C3 will be reduced. And next diagnosis is, next investigation is renal biopsy. Renal biopsy is rarely indicated. It usually, if there is a low C3 level for more than 12 weeks, or if there is impaired renal function for more than 7 to 10 days, in that case only we will need renal biopsy. Otherwise, renal biopsy is not needed in case of PSGN. And we can diagnose post-streptococcal glomerulonephritis with microscopic findings. In immunofluorescence, it will characteristically appear as a lumpy, bumpy or starry sky appearance. It is because of the immune complex. You can see some chaotic appearance of immunofluorescence. It is due to the immune complex deposition. And in diseases which do not involve immune complex deposition, in immunofluorescence it will appear as a linear pattern. When there is immune complex deposition, it will appear as this lumpy, bumpy pattern. So from immunofluorescence, we can identify this immune complex deposition as lumpy, bumpy or starry sky appearance. And in electron microscopy, we can see the subepithelial hump. So in this area, you can see the subepithelial hump due to immune complex deposition. These are the microscopic findings: lumpy, bumpy appearance and subepithelial hump. And then coming to the management, there is no specific treatment for this condition because it will resolve by itself. So we should treat symptomatically. So since we have seen that the child will come with hypertension, right, in the first slide, so we should treat that hypertension with calcium channel blockers like amlodipine and nifedipine, and the disease resolves itself within few days to few weeks. And normally the ASO titer and BP will become normal by 4 to 6 weeks, and C3 will become normal by 8 to 12 weeks. You can remember in this way: 4 to 6 weeks is for ASO titer and BP, blood pressure. You have to multiply it with 2, so you will get 8 to 12, right? 4 into 2 is 8 and 6 into 2 is 12. So we can remember in that way. C3 will be normal by 8 to 12 weeks, and ASO titer and BP will be normal by 4 to 6 weeks. And microscopic hematuria can persist up to 1 to 2 years. So with this, we are completing post-streptococcal glomerulonephritis. The basic, the recap of what we have seen is, you have to remember the characteristic features, those 5 features: hematuria, RBC cast, dysmorphic RBCs, mild proteinuria, edema, hypertension. Azotemia, if you remember, you can write, or else it's not a big deal. So hematuria, you should remember: RBC cast, dysmorphic RBCs, mild proteinuria, edema and hypertension. And then you know the story of PSGN, the streptococcal infection occurs after some weeks. The immune complex, due to the combination of antigen and antibody, will deposit in the kidney and impair the renal function. That will present as glomerulonephritis. And since it occurs after the streptococcal infection, it is called as post-streptococcal glomerulonephritis. And then you should remember 3 investigations: ASO titer or anti-DNase B antibody titer, and serum C3 levels, renal biopsy in case of low C3 if it persists for more than 12 weeks, or impaired renal function for more than 7 to 10 days. These 2 conditions only we will do renal biopsy. And immunofluorescence finding, electron microscopy findings, we have seen that lumpy, bumpy and subepithelial hump appearance. And management, it resolves by itself. We should wait and watch, and if symptomatic, we should provide, if the patient is hypertensive, we should give amlodipine and nifedipine. So this is all about PSGN. Thank you.